midline, a little lower port, second port lower. What is your opinion about this? Yeah, people may just do like this. Maybe it is lower than.
No, I would say that surgeons should always become cerebral laborers. Surgeons should never ever become manual laborers. What I mean to say, that it is all up to your comfort level. For example, you are talking about TEP, infraumbilical first port, or all midline ports. Yes, that's what I'm saying. And now we strongly believe that there are school of people, there are people who are making ETAP by going higher on the left side, the primary port, and two secondary ports, one in the midline and one laterally. But we are making two secondary ports umbilical midline only because we want to make only 3 ports. That means one primary port of 12 mm and 2 5 mm ports in the midline in the infraumbilical region as we were doing by TEP. And then we are able to address both bilateral hernias. Whereas there are surgeons who would place lateral ports on one port on the lateral side, one on the midline, and then once they move to the other side of the table, then they make another port for the left-sided inguinal hernia, for example. But our thoughts are, please do not rectify these port placements. Our feeling is that if you are having a good height, if you are able to do like this, nothing like it. Whatsoever works best in your hands, please carry on following. There is no hard and fast rule that one should always make the diagonal ports or one should always make the midline. Whatsoever you are comfortable with, carry on doing it.
And last question from my side. What about excision after pseudoscience in private hernia? Because it causes pain. Stuck to the Cooper's ligament or something.
Wonderful question. Answer is, rather than pain, I am much bothered about seroma. In the sense that if I leave a large direct pseudosac behind towards the scrotal sac, and if I leave some blood also, then the chances of seroma will definitely be there. So it is good idea to, if you are able to excise it, nothing like it. If you are able to fix it to the Cooper's ligament, nothing like it. Ultimate answer is that you should reduce the incidence of seroma rather than causing one tack onto the Cooper's ligament is not going to cause much pain, because in any case, when we are fixing the mesh, we are fixing it to the Cooper's ligament. So we have to apply 2 or 3 tacks, so that pain will not be because of this.
Sir, one last question.
Sure.
Hello.
Yes, sir, please.
Sir, in a large direct hernia, would it be sufficient to go 1 to 2 centimeters to the upper side? Would it be sufficient in a large direct hernia?
No, I mentioned that if we are dealing with a direct defect, maybe 4 centimeters defect, then it is a good idea to dissect so much that we are able to cover it by 4 to 5 centimeters. Means the 2 centimeters we are pushing the mesh into the cave of threads. Yes, we should always push the mesh towards the contralateral side also, so that will cover approximately 4 centimeters from the defect. Again and again, intention is we should not have the mesh in the scrotum. We should not have the recurrence. So thinking is that please cover the direct defect and indirect defect adequately, fix them well. In situations in which, for example, direct defect is there, I may place 3 tacks onto the Cooper's ligament so that my mesh does not go in. If I am dealing with the indirect sac, then I would place 1 tack, maybe 1 or 2 tacks onto the anterior, close to the anterior superior iliac spine, laterally, higher up, above the level of iliopubic tract, so that I do not cause any nerve injuries and I am not responsible for any iatrogenic recurrences.
Thank you so much, sir. Thank you.
Sir, thank you very much.
Yes, sir.
Any questions from? Yeah. So thank you. One question.
Yeah, sure.
I did not see you open the posterior rectus tube. So many people, including the originators of this procedure, say that to be able to get good visualization, you should divide the 2 inches of the PRS, and which I would like to hear your comments about it. Do you do it? If you don't do it, what do you think about the safety or non-safety about it?
I must compliment your observation. What I mean to say, you did an excellent observation, that I do not believe on cutting the posterior rectus sheath because unnecessary you are weakening it. One. Second thing is, in the initial phase, when we started our E-TAP career, we were using a port, the OptiView port of a normal laparoscopic length. Then definitely we had some challenges in going to the right side. If I am working from the left side, then I had some challenges, and then at that peak, at the top of the nadir, I had to cut maybe posterior rectus sheath. But now we have graduated ourselves to use the bariatric length OptiPort, so that ultimately if I have to see inside, I slide in, glide in, and my cameraman goes like this. It is just retracted away. Posterior rectus sheath is just retracted away, and then we are able to reach up to the anterior superior iliac spine 2 centimeters above. And again, when we are pushing the mesh, we just withdraw and go in with the port, and it rests comfortably without even hurting the peritoneum or the inferior epigastric, because it is a long length bariatric OptiView port. Yes, but one should carry on evoluting. Yes, sir.
Sir, why mesh is mileage despite the adequate size of the mesh?
Sure.
And if they migrate, do you fix the mesh, or does the fixation of the mesh prevent the migration?
Good idea. Our thinking is that if you do not fix the mesh, and we know the situation, in the initial phase, only we had patient in which one could feel the mesh in the scrotum done by somebody else. When I asked him, do you fix the mesh? He says, no, I never have fixed it mesh. But our thinking is that we always fix by 2-point fixation or more for large defects, but we always fix the mesh. And again, the size of the mesh has to be at least 15 by 12, and the margins I have already told how much one has to cross, and one should always go up to the mid belly of the sauce also.
So do you close the refractor?
No. We in such situations, yes sir. Sure. Thank you. I will talk. Sure, sir. Sure.